Good evening to everyone present here with us today. This is Priyon from IJCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Aviral Roy. Sir is the medical director and critical care of Secaucus University Hospital. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is tackling healthcare associated infection through better antibiotic practice. Now, with this, I would like to hand over the session to Sir so that he can begin with his talk. Over to you, Sir.
Thank you, Shreyan. And hello and welcome, everybody. And thank you for coming in for today's lecture. I'm aware that this is a Friday evening for you and you all may have plans. So I do appreciate, you all taking your time out and really talking about this thing, which is a real health crisis, especially in India, given our high rates of what we call multi-drug resistant organisms. So with that in mind, anything that we can do to control this epidemic and pandemic is definitely going to result in patient lives being saved, less fewer people being hurt, lesser mortality, lesser morbidity, and of course lesser cost incurred to patient. So with that in mind, let's first talk about the stage. What is the current scope of the disease and where are we right now? So let's call it HAIs. Hospital acquired infections remain a major cause of morbidity, mortality, and cost in the hospital, up to 3%. So 1 in 31 of any hospitalized patient at any given time, on any given day, has a hospital acquired infection. A large part of this is rising complexity of cases, aging population, use of large amount of support services like ECMO or CRT, which is renal replacement therapy, immunosuppression, transplant of result has and increasing availability of these services resulted in an increasing rate. This graph over here shows the boxes are gram positive organisms, the circles are gram negative, and as you can see, there overall there's been an increasing trend since 2003 all the way up to 2022. What are the commonly seen organisms? CRE stands for carbapenemase resistant Enterobacteriaceae. CR crab, so that's CRE. Crab stands for carbapenemase resistant Acinetobacter baumannii. ESBL is, of course, an extended spectrum beta lactamases, so E. coli, pneumoniae. MRSA, which is methicillin resistant Staphylococcus aureus, is showing increasing reemergence in several large ICUs. And of course, as far as Canada is concerned, we all heard of Canada auris, which is a extremely virulent as well as drug resistant type of candida, which is now resulting in multiple outbreaks in ICUs due to very high antibiotic pressure. However, HAIs are not isolated events. They are usually systemic events and they represent systemic failures or multiple point failures in the hospital life cycle, and of course are events that can be improved upon. So this is a graph that basically shows what is the likelihood of somebody having an infection, and as they get more of these conditions, what's the cumulative incidence. So just having a prolonged stay in the hospital, not even ICU, for more than 5 days automatically puts you about a 25 to 30% risk. An indwelling catheter, now your risk is approaching 40-45%. Along with that, receiving antimicrobial therapy in the last 90 days, you're now at 60%. Previous history of multiple drug resistant organisms or colonization, you're at 70-75%. If you're an ICU patient, you're up to 80. Previous hospitalization in the last 90 days, you're up to 80-85-90%. Recent surgery or trauma, transfer from other the unit, and you're already approaching 90+%. And if you're on immunosuppressive therapy and have all of these above risk factors, you're almost a 100% chance where you're actually going to have a multiple drug resistant organism. Antibiotic practices drive hospital-acquired infections. What are these? Unnecessarily broad antibiotics results in selection of multi-drug resistant organisms. Delayed de-escalation results in persistent antibiotic pressure and again results in more resistance. Of course, duration of antibiotics longer than what we need results in C. diff and VRE colonizations, inadequate dosing, treatment failures, and emergence of resistance. Overdiagnosis of infection. What does this mean? We are giving antibiotics for viral infections. We are giving antibiotics for non-infectious causes of fever or non-infectious causes of inflammation. Inappropriate device days, that is, you're putting in lines that don't need to be there, you're doing cultures that don't need to be done, you're overdiagnosing infection, results in overuse of antibiotics. Results So this is why stewardship is important for patient safety and not cost control. People think antibiotics stewardship is for cost control. No, it's more for patient safety. And of course, as we can see in the epidemiology and burden of the disease, high risk countries are either ones with a lot of healthcare activity and a lot of devices, or countries with very very high rate of inappropriate use of antibiotics. In countries where they more or less control the use of devices or procedures along with antibiotic use, you can see the risk of antimicrobial events or resistance starts to go down. What's the landscape? What are some common types of uh, antibiotic acquired infections commonly in the ICU, because that's where we see most of these? CLABSI, that's a catheter associated bloodstream infection. COTI, which is catheter associated UTI, urinary tract infection. Ventilator associated events, they started as a VAE, which can then progress to a VAP, which is ventilator associated pneumonia. C. diff, of course, we all know, surgical site infections. MDRO, colonization and infections. And what are the drivers of these? Oh, sorry. What are the key drivers? Of course, devices, which includes lines, which includes cannulas, which includes stuff like ECMO cannulas or being on CRRT. It also includes stuff like joints. It includes pacemakers, temporary or permanent. Host factors basically means age, comorbidities, pre-existing colonizations, immunosuppressive states. Antibiotics, of course, what are they getting? Targeted antibiotic, broad spectrum. And of course, workflow variability, which is how the ICU works. So, what are infection control practices, what are antimicrobial stewardship protocols, and so on and so forth. Quick list of common organisms and the types of, and the amount of drug resistance that you see, and you can see it is extensive, right? If you look at a drug like acinetobacter, if you look at a bug, not drug, like acinetobacter baumannii, it is usually baseline broad spectrum resistant to almost everything. You have a few chance with with aminoglycosides over here, but overall otherwise you're more than 90% resistance to most drugs. Klebsiella, another drug commonly seen with very, very high rates of resistance to regular antibiotics. Maybe some sensitivity over here to the carbapenems, but otherwise very, very high rates of resistance. We consider anything over 10 to 15% as a high rate of resistance, because that basically means you have 1 in 5 chance of treatment failure. Pseudomonas, again, very, very high rates of drug resistance, practically resistant to everything. You have some resistance to aminoglycosides over here, but that's about it. And E. coli, you still have some sensitivity to aminoglycosides, but otherwise, and to the carbapenems, of course, but otherwise very very resistant. Another organism commonly seen in hospital acquired infections. This is an example of an antibiogram. This is what we use when we try to make a decision on what antibiotics to use in the hospital. This is, of course, not complete because it does not mention which site. So this is just a total number, but of course, we decide antibiogram based on the site of infection. So there's a respiratory tract, bloodstream infection, surgical site infection, soft tissue, skin infection, or of course, urinary tract infections. How do antibiotics promote hospital-acquired infections? One, microbiome disruption. What is this? When the antibiotics disrupt the trillions and trillions of cells which are within your gut, leading to colonization by drug-resistant organisms. This results in stuff like VRE, which is vancomycin-resistant enterococcus. C. diff, of course, we all know, and Candida species within the gut. Selection pressure, when you use a broad spectrum antibiotics, you kill all the sensitive bugs, leaving only the resistant bugs. And if you give this for too long or an insufficient duration of antibiotics, so let's call it inappropriate duration, you lead to stuff like CRE, ESBL, MRSA clusters. Device colonization, as these bugs try to hide from the antibiotic. They result in biofilm deposition, which prevents the antibiotic from actually reaching the organism. This is, of course, made problematic if you have devices, plastic, metal, wires, anything, which, of course, it gives a surface for the bacteria or the fungus to sit on and create a biofilm around it, and then the antibiotic can't penetrate. Prolonged hospital stay due to antibiotic side effects, antibiotic associated issues, and of course a higher risk of exposure to antibiotics, resulting in higher hospital acquired infection risk. And of course, colonization pressure. Why? Because the hospital tends to have very, very high rates of drug resistant organisms, which then results in increased transmission in the ICUs, because these are places with high rates of contamination as well. I say antibiotic life cycle in the hospital, but actually the antibiotic life cycle in communities, right? And we often see this. You get antibiotic production, they go to the hospital waste treatment, and wastewater, it lands up in the environment. People eat antibiotic, People eat antibiotics with probiotics. It goes into wastewater, it then goes into the environment. Agronomy, which is basically apply, and a lot of antibiotics are given to our livestock and feed. They then create manure, which they poop out antibiotic or pee antibiotic, which then makes its way into the environment. And then eventually all of this leaches gradually into our food supply as well, again. However, as far as the hospital is concerned, there are many places where you can intervene in the antibiotics. The number one being, let before we even start it. What's the number one cause of inappropriately starting antibiotics? Diagnostic uncertainty. Remember, fever is not an infection. Fever can also happen from non infectious causes. So you can get leukocytosis from stress, steroids, seizures, bleeding. Any acute stressor on the body will lead to leukocytosis. All fevers are not necessarily infectious. If you're getting a chest x ray, remember, not every infiltrate is a pneumonia, it can be atelectasis. You can have, if you have infiltrate, it can be an infection or pulmonary edema. And aspiration pneumonitis versus aspiration pneumonia is very different. Aspiration pneumonitis is just chemical irritation of the lung. It looks like infiltrate, but it's not infectious, versus a true aspiration pneumonia. Remember, mild increases in procalcitonin and CRP are non-specific markers of inflammation, not necessarily infection. So you don't have to start antibiotics in every single time. And remember, if you don't know the source of what infection you're having, you cannot decide on an appropriate antibiotic. So you do not know the right antibiotic. So this is an important uh, fact to remember and keep track of. So, what are the moments that matter framework? And this is from a song that I really like, Moments Are Missing. So, moment one, should we start an antibiotic? Only when there's clinical and biochemical and imaging data to support infection. Moment two, have you obtained proper cultures? Get two sets before antibiotics, or urine cultures only if you have urine symptoms. Get respiratory cultures only if you see new infiltrates and worsening oxygenation. And new infiltrate without changes in oxygenation may just be positional related atelectasis. Maybe try to get your patient to sit up, do some pulmonary toileting, spirometry to help out. Are we using the right empiric therapy? Matched to the syndrome, that is it a lung syndrome, is it a chest syndrome, urinary tract syndrome, abdominal syndrome, blood? Because your antibiotic choices will matter. Adapt to your local antibiogram, which is what are the common infections in your hospital, what are the common resistance patterns and sensitivity patterns, and of course, narrow to patient risk factors as to, are they immunosuppressed, did they get chemotherapy recently, do they have an invasive device, how long do they have an invasive device, what type of surgery do they get, abdominal surgery, extremity surgery, heart surgery, was it a emergency surgery, was it a dirty surgery, that is they didn't have time to do quick good antisepsis, was it abdominal surgery with peritoneal leakage or fecal leakage or fecal spillage in the peritoneum, things that you have to review. Moment four, can we narrow our antibiotic choice? So review culture data at 40 to 72 hours. What is the nose MRSA PCR status? If the nose PCR is negative, can we stop the vancomycin? If culture negative 72 hours, can we maybe go from broad spectrum to narrow spectrum antibiotics? and something that you review every single day in the ICU, or for the matter anywhere in the hospital or on any patient. Moment 5, can we stop the antibiotic? Stop. No source, cultures are negative, patient symptoms are resolving. So you can consider stopping antibiotic. So, what are some evidence based antibiotic practices that we can use? Things you should not treat. So, starting appropriately, asymptomatic bacteriuria, chronic Foley colonization, sputum cultures that are positive without clinical pneumonia, that is, no fever, no chills, no infiltrate on chest X-ray, no need for increased oxygen. However, their cultures are positive. What do you do with that? You ignore it. Isolated fever post-procedure, transfusion, or neurologic exam. Isolate or not just a neurological exam, but neurological exam if somebody would say a head bleed or a stroke. These are common causes of non-infectious fever. Low empiric antibiotic therapy should incorporate local antibiogram, prior MDR colonization, recent antibiotic exposure, and of course the immune system status. Always remember, cultures first, then antibiotics, unless of course they're in shock. Remember, source control is mandatory. Antibiotics cannot rescue inadequate source control. Early drainage improves survival and reduce hospital-acquired infection risks. So, example, intra-abdominal sepsis, get a surgical consult. Intra-abdominal abscess, cholecystitis, acute gallbladder. Nephrolithiasis, or maybe something like hydronephrosis that's infected, right? Empyema, chest wall, you put a chest tube and consider lytic agents. Obstructed urinary tract, you want to do a stenting, you might want to do a nephrostomy. Necrotizing soft tissue infection, not responding to initial antibiotic therapy. They do not need to be escalated on antibiotics, they need to go to the operating room. Common reasons to give unnecessary antibiotics. Coagulase negative staph is a contamination, not a collapse. Candida in urine is colonization, that's not infection. Positive tracheal aspirate without new VAP criteria, which is if you are taking repeat cultures and the patient is stable on the ventilator, no signs of distress, no increasing oxygen requirement, no infiltrate. Do you have to treat it? No. If you see enterococcus in urine without UTI, this is very, very common. Fecal contamination, you don't necessarily have to treat. Mixed flora and sputum, which is usually just mouth organisms coming in. This is colonization, does not need to be treated. Avoid repeating cultures unless clinically indicated, because whenever you get a culture you have to be ready to know why are you getting it and if you want to treat it or not. If the patient is stable, why are you getting a culture to begin with, right? Unless of course you're following a very specific protocol like say MRSA, where you're trying to repeat cultures as a part of protocol to determine when to stop antibiotics. So in apart from very very specific cases, overall avoid repeating cultures unless a patient has a clinical reason to do so. Aggressive de-escalation strategies, what are these? Reassess at 72 hours, 48 to 72 hours. Narrow culture results based on narrow the antibiotics based on culture results, susceptibilities, and clinical trajectory of the patient. Consider discontinuing MRSA coverage, which in India is usually teicoplanin or vancomycin. So if MRSA nasal PCR is negative and pneumonia is suspected, then you can usually stop the vancomycin and continue with another agent. Transition to oral drugs as soon as possible whenever feasible or clinically indicated. Remember, longer courses result in higher rates of resistance, so we have to optimize duration of antibiotic. What is for community acquired pneumonia? 5 days. Hospital or ventilator acquired pneumonia, maybe 7 days, which can be shortened if they have rapid improvement. Pyelonephritis, 5 to 7 days. Intra-abdominal infection, where you have source control, 5 to 7 days. Uncomplicated gram negative bacteremia, 7 days, but of course you have to see how the clinical course is going. Skin and soft tissue infections, 5 to 6 days, unless of course it's something like osteomyelitis where you might need longer courses. Remember, longer courses increase risk of organisms such as C. diff, Enterococcus, MRSA, MDRO, Acinetobacter, Klebsiella. These are the MDRO organisms. Candida, Candidemia, and of course, you're exposing them to increased rates of drug toxicity from the very antibiotic that you're giving them. Then what this is, you need pharmacokinetic precision, which is Dose your antibiotics appropriately because underdosing results in therapeutic failure and increased rates of resistance, whereas overdosing results in AKI, neurotoxicity, peripheral neuropathy, loss of hearing, you name it, it's there, right? Along with an increased risk of hospital-acquired infection because now these people have to stay in the hospital longer. So, what are some tactics you can use? Use weight-based dosing, especially for beta-lactams and vancomycin. Remember that beta-lactams or any drug with time-dependent killing benefit from extended infusion. Adjust your dosing for patients on dialysis, CRRT or hemodialysis. If they have hypoalbuminemia, you need to readjust your dosing. And of course, if you're using ECMO and ECMO circuits, where you might have binding within the ECMO circuit, you might have binding within the ECMO filter, or you have increased rates of loss through the ECMO circuit, you might need to redose your antibiotics. What's a quick ICU daily stewardship bundle that we can use on day one? What's the indication? Our culture is done. Are we using the right spectrum of antibiotic? Day two, day three, what are the culture results? If they're positive, can we narrow it? Can we switch to oral agents if possible? Day five, can we stop it? On day seven, you do a red flag review, which means any antibiotic over 7 days must be, justified. Why are we doing this? Integrate the pharmacist in your daily rounds. Integrate infectious disease into your daily rounds. We call this multidisciplinary rounds. So you want to do multidisciplinary rounding on all your patients to kind of figure out what we want to do when we want to do. If you have electronic medical record in your hospital using EMR forcing functions, which is basically on day 5, day 7, or whatever your hospital antimicrobial stewardship committee decides, automatic timeout reminders, duration defaults, which means like all antibiotics will only be prescribed up to say maybe 3 days for broad spectrum antibiotics, 5 to 7 days for narrow spectrum antibiotics, and have to be reordered. Too often do antibiotics get forgotten about or dropped off. So there are automatic termination events for antibiotic durations, unless, of course, justified where they then need to be reordered. Preventing device related infections. So remember, broad spectrum antibiotics fosters biofilm formations on central lines, endotracheal tubes, Foley catheters. Overtreatment results in increased device days because waiting for negative results. So you know what? And of course, if you have a device that you don't need or can be removed, please go ahead and do so. The number one way to prevent a COTI or a CLAPSI is not having a Foley or a central line. So if you need an infection, if you need a line, of course use it, but if you don't need it, remove it sooner rather than later. Antibiotics do not prevent device infections, remember that. They just lead to worse colonization, because if you do have a device, antibiotics are not going to prevent colonization of that or an infection of that. Okay, so don't give an antibiotic thinking you're going to protect the line. It's not going to happen. So what are the device strategies you can use? Minimize device stays, early extubation, early Foley removal, using peripheral lines such as a midline versus central line. Avoid sending cultures from chronic devices unless there's evidence that they're infected, because they get colonized and then you're stuck with a positive device culture and then you don't know what to do with it. Avoid unnecessarily line changes. That's a line holiday myth. Once you put in a line, the old strategy used to be, don't leave it in for more than 5 days, 7 days, 10 days and change it out. No, the highest risk of an infection is when you put the line in or take the line out. Not out, when you put the line in. So don't change the line unnecessarily. If you need it, put it in. If you do not need it, take it out. Don't need to continuously, cycle through the line. And if a side looks infected, take it out. And if you still need a line, desperately put it on a completely different side. Use objective VAP criteria. Avoid diagnosing colonizations and infections. What does this mean? If patient has a positive culture but normal oxygen, or improving oxygenation, no new infiltrate, no new fevers, but you got a culture for whatever reason, or your colleague ordered for whatever reason, A, that culture should not have been ordered, but B, no need to treat that positive culture. Avoid empirical antibiotic antifungal agents unless there are very, very strong risk factors for fungal colonization or fungal infection. Not even colonization, fungal infection. So, for example, in a CLABSI versus contaminant case, if you get one or two blood cultures that are positive for coagulate negative staph, no evidence of sepsis, you do not need antibiotics. This is just contamination. You don't need it. VAB versus colonization, like we discussed. For example, you get a sputum culture with multi-drug resistant pseudomonas, but no new infiltrate, stable oxygenation, no new fever. This is colonization, not VAP, no need for antibiotics. C. diff after prolonged piperacillin tazobactam. First of all, 14-day empiric course of antibiotics will lead to severe high risk of C. diff. So what we want to do not avoid the prolonged piperacillin tazobactam called zosyn or piptazo or tazobactam, whatever your hospital uses. These should be restricted to 3 to 5 days, maybe up to 7 days maximum. And of course, then de-escalate as per the local antibiogram of your hospital. Remember, system stewardship and culture. Stewardship is all of these things: a good strategy, multidisciplinary intersectoral collaboration, good clinical governance and accountability, good design on good systems and good practices within your hospital, making sure these designs and systems and processes are regulated and adhered to, and of course, getting data and intelligence on to how your processes are performing and then modifying them accordingly. So, what are the hospital level strategies? The core elements of antimicrobial stewardship program, that's ASP: leadership commitment, accountability, pharmacy expertise, actionable interventions, tracking, reporting, education, of course. You want antibiograms to accurately depict what antibiotics to use. So you want good quality data. You want a good quality ability to detect multiple drug use, inappropriate duration, whether that's coming from your electronic medical record, from your pharmacy via automated protocols, automated discontinuations, but you want a good policy over there. And of course, having outbreak surveillance tracking, where if there is an outbreak, you can quickly contain it and do a root cause analysis as to why this is happening, and modify policies, procedures, or maybe even practices, so as to, or maybe training to help control these. Changing the culture, of course, we're talking about the hospital culture. Normalize that stopping antibiotics is a good thing, it's a positive change. Having de escalation protocols as routine practice. Empowering your nurses and pharmacists to challenge unnecessary antibiotics. Figuring out that we have cognitive biases and how to fix that among our physicians and prescribing treat doctors. Do not necessarily anchor an infection and look for non-infectious causes of whatever your patient is having. Treatment inertia, which basically means once something is started, you just don't want to stop it just because, let's see how it goes. That is something that is actually actively harmful, should be avoided. What's called defensive medicine or fear of litigation. Remember, being litigated for getting is not the appropriate reason to not provide optimum care for your patient. And having transparency in your processes, feedback loops, and in having ICU level dashboards, which basically means tracking in each ICU their outcomes, and everybody in the ICU is aware of what's going on, things that you're doing to aggressively treat this, and being open and transparent about it. Take home messages: most antibiotic or hospital associated infections are driven by unnecessarily antibiotics. Smart antibiotic. So what you want to do? Smart antibiotic choices, which reduce mortality, length of stay, multi-drug resistant organism, and costs. The shortest effective duration is the safest duration of antibiotic. You want to build a culture, systems, and routes that are multidisciplinary in nature to achieve these goals. And remember, a high performing ICU, or for the matter, hospital, is a low antibiotic hospital. Do not price yourself on the antibiotic usage. You want to price yourself on low antibiotic usage. These are my references. You're all welcome to take a look at these. And thank you for listening. And I'll take any questions if you have anything. And I think we completed with 1 minute to go. Thank you.
Thank you so much, sir, for this wonderful presentation. We do have some question from our audience if you'd like to take that up.
Sure.
So the first question is: in your experience, how often do you broad spectrum antibiotics get started without adequate microbiology input?
So I work in an ICU. I see a lot of patients, who have infections, of course, or who need ventilation, septic shock, UTI, whatever. 100% of my patients will get broad spectrum antibiotic, but 100% of them will also get initial cultures. So you don't necessarily need microbiology to come in at the very beginning, right? It's not possible. You have 1 hour to start antibiotics as per the surviving sepsis guidelines, right? I can't get antimicrobial review in 1 hour, and cultures will anyways take 48 to 72 hours to come back. So you start your broad spectrum antibiotic. I am aware of my local hospital antibiogram. I have availability on the computer at all times. I can always open it, look at this, site. So if it is a respiratory tract infection, if it's a gut infection, intra-abdominal, urine, blood, whatever, I know what my common organisms are. I know what my resistance pattern over here is. So we start the antibiotic, broad spectrum antibiotic initially, and then we get the what we call ID consult over here, infectious disease consult, who comes in, takes a look, and then we actively during rounds on a daily basis discuss what antibiotics we're giving and what can we stop, and it's a part of our multidisciplinary round. So 100% of my patients will get an antimicrobial review if they're on broad spectrum of my broad spectrum antibiotic coverage in my ICU.
Thank you, sir. The next question which we have, what are the key indicators you monitor to measure ASP success?
So, of course, the number one indicator of ASP success is actually your rates of, hospital-acquired infections. What are the common ones we track? Of course, CLABSI, we track COTI, we track C. diff, we track ventilator-associated events, ventilator-associated pneumonias. On the surgical side, need for surgical re-exploration due to skin and soft tissue infections. Skin and soft tissue infections are usually tougher to track because the patient may get discharged after surgery and come back and only round in the OPD, so that's difficult to follow up on. But then that is something we do track. The way to track that is if any post-op patient has been readmitted for IV antibiotics, that's a major infection. You track your requirement or total requirement of antibiotics. You track the total number of days on average a patient has been getting antibiotics for. You track a number of line days, so you track your number of central line days. You track number of Foley catheter days. We track indications for Foley catheterization, appropriateness of Foley catheterization. We track the rates of blood cultures we send, or not blood cultures, any cultures, the rates of C. diff testing that we send. We track the rates of appropriate testing of C. diff. So if somebody is on, say, docusate or colase or some sort of laxative and you're sending C. diff on them, then that's inappropriate, right? So you track, there are multiple things that you can track. Then hand hygiene compliance, of course, hand washing compliance is a big thing.
Thank you, sir. There's one last question. How important is the role of stewardship round and real time prescription audits?
So, of course, and as we discussed, you can't have any of this without stewardship, right? So, 100% you need a stewardship program, an aggressive stewardship program that's backed by hospital leadership and with a commitment to improve and to make the changes which they recommend. So there's no doubt about that. Prescription audits, of course, you have to do them just because of you want to see what's your rate of broad spectrum antibiotic use, what's your rate of inappropriate antibiotic use, what's your rate of appropriate antibiotic use, what's your rate of inappropriate duration, right? Because remember, when we write a prescription, there are many aspects to it. Is it the right dose? Is it the right drug? Is it the right dose? Is it the right duration? Is it the right frequency? Is it the right route? So the only person who can really order that is either the ID physician, the microbiology physician, or the infection disease uh, a specialist pharmacist. So you have to do that, and this become even more. Of course, you want to do prospective audits, but these become even more important when you have retrospective audits. If you have a acute surveillance, or doing a root cause analysis of what happened. So they're absolutely essential to the aspect of antimicrobial stewardship.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, any take home message from your end?
Yeah, especially Remember, not every fever is a bacterial infection. You get viral infections. You don't have to treat those, especially in the outpatient world. For if there are any non-physicians over here, is if you get a cough and cold, you don't need an antibiotic immediately. Just a regular paracetamol will work. If you're having cough, cold, sore throat, ibuprofen will work. Your antihistamines will work. You only need them if you have bacterial signs of bacterial infection, which are less than 2 to 5% of most cough and colds. Same thing in hospital. Not every fever is an infection. First, rule out non-infectious causes before you start antibiotics, unless there's a patient who's in septic shock or very, very critical, in which case, it's dangerous to wait. But if you can wait, do wait and investigate your patient appropriately before starting antibiotics.
Thank you, sir. Thank you so much for giving us such wonderful view on this topic, and thanks from our audience as well. It's our pleasure to have you here, sir. That you have joined today. Thank you
Thank you so
so much.
much, you all. Have a good day.
Thank you,
Thanks.
sir. Same to
Thank
you.
you, everyone. You too. Bye.